talking about cardiogenic shock. Cardiogenic shock has a high mortality and management remains challenging despite advances in therapeutic options. We know that after an MI, the mortality has come down significantly, but for cardiogenic shock, we have not seen a significant reduction in mortality despite all the advances in medical care. It's caused by impaired myocardial function, resulting in diminished output and end organ hyperperfusion. Presence is hypotension, which is refractory to volume resuscitation with features of end organ hyperperfusion requiring pharmacological or mechanical intervention. Acute MI accounts for more than 80% of patients with cardiogenic shock. Now, what is shock? For everything, we have to have a definition. So you can see that the definition of cardiogenic shock itself is different. In the shock trial in 1999, it was systolic blood pressure less than 90 for more than 30 minutes, or vasopressors to maintain systolic blood pressure, end organ damage, as evidenced by urine output less than 30 ml per hour, or cold extremities, and cardiac index less than 2.2 and pulmonary capillary wedge pressure more than 15. But when you come to IABP Shock 2 trial, that's in 2012, that's more than 10 years later, the definition had changed. It has mean arterial pressure less than 70, systolic blood pressure less than 100, end organ damage here now at urine output less than 0.5 ml per kilogram per hour, or lactate, which is more than 2. Lactate has come in new. And then the ESC HF guidelines 2016, again, blood pressure less than 90, clinical and laboratory. So you need to have a uniform definition because you're talking about different things at different times and you wouldn't know what is really the one you're talking about, for which Sky came with a uniform criteria for shock in 2019. And based on this, and why the new criteria? You have to have a classification which is simple and uniformly adaptable, suitable for rapid assessment. It has to have multidisciplinary applicability, usable across all clinical settings, like in the emergency. Usable across all clinical settings, whether it's emergency, ICU, because shock is treated not only by the cardiologist, by the ICU professional and even the emergency physician as well. So it should be usable across all settings, should be actionable. So if you say shock is in class A or B, C, you should have a definite plan of action for everyone and should lead to change in behavior, facilitating the hub and spoke model of shock care, recognize deterioration and adverse outcome, and should have prognostic discriminatory potential. These are the reasons why the new criteria came. So you have A, B, C, D, and E. A is at risk, beginning, classic, deteriorating, and extremis. Now we need to spend a little bit time on this because we all have to be aware of what is what. A is at risk, which means the patient is a high risk of developing shock but is presently stable. So any patient who has a large MI, prior MI, acute and chronic heart failure comes into this category. Physical examination would essentially be normal labs, hemodynamics, blood pressure more than 100, and cardiac index and CVP normal. Now, PA saturation is something which has come up new for all patients in shock. They advise right heart catheterization, and PA saturation is important. Signs of heart failure, elevated JVP, basal crackles, but they still are warm and well perfused and strong distal pulses, normal mentation. Normal lactate, but deranged RFT is common here, and you have elevated BNP. Hemodynamics, blood pressure would be less than 90, pulse rate more than 100, and cardiac index is still more than 2.2. But then you come into C, or that's classic cardiogenic shock. Here you have hyperperfusion requiring intervention and hypotension. The patient looks unwell, ashen and motley skin, volume overload, extensive rails, class 3 or 4, or needing mechanical ventilation or BiPAP, and urine output less than 30 ml per hour. Here, the lactate would be more than 2. You have doubling of creatinine, deranged LFTs, and elevated BNP. Blood pressure will be less than 90 and requiring either pressors or mechanical support to maintain blood pressure. Cardiac index would be less than 2.2. Now, deteriorating is same as class B, but you have multiple pressors or MCS. MCS is mechanical circulatory support to maintain the blood pressure. So from B, you have gone on to worse, C. Cardiac index would be less than 2.2, wedge pressure more than 15. Now you have another term, which is a cardiac power output, which I will come to later. And finally, E is the patient is sick, which they say the patient is trying to die. The patient would be on CPR, pH would be less than 7.2, lactate more than 5. So when you have a patient in stage E, whatever you do, the patient would be sick. So it's one of the ways by which you can prognosticate the disease and even explain the things to everyone concerned, which stage of shock you are dealing. Now, other categories to stratify would be arrest modifier or A. So when you have a cardiac arrest in a shock, however brief it may be, that puts a patient onto a higher risk category. So when you're talking about shock, you have three categories. You have the clinical features, biochemistry, and hemodynamics, based on which you would categorize the patients into which category they fall into. Now, once you have the definition, you would be looking at management. And management of shock is IV fluids, oxygenation and ventilation, vasopressor support, hemodynamic monitoring, and MCS devices. Now, fluids and oxygenation, which is fairly common and we should all be doing it, spend some time on the other three. Now, these are the systemic vasopressors. This is the whole array of vasopressors that we are using it, of which the most important thing is any patient with shock, the first line would be norepinephrine. This has the most data. You have reduction in mortality with norepinephrine. So any patient with shock, the first drug would be norepinephrine. Epinephrine and dopamine, this is the combination which is used frequently, would be the second line, and epinephrine especially in anaphylactic shock. Vasopressin and phenylephrine are the purely vasoconstrictors, and for shock they're useful. Dobutamine is extremely good if you are looking at RVMI, but you must understand dobutamine causes venodilatation and can cause hypotension, so that should be something which should be kept in mind. Levosimendan is a new drug, relatively new drug. It's a myofilament calcium sensitizer and potassium channel modifier, and this is extremely useful if MCS is not an option or if you can't use MCS and you need something to increase. Levosimendan is an option that can be tried. Now, hemodynamic monitoring, anyone in the ICU would know all these things, but you would be measuring ECG. Arterial blood pressure monitoring is important if the patient is in shock. You should have oximetry, temperature and respiratory output, and urine output. Urine output hourly is something which can be easily done in any ICU, and we should all be doing it. Now, PA saturation and pulmonary capillary wedge pressure monitor via PA catheter is something which is frequently used in everywhere in the Western countries, but you must understand it's controversial and does not confer mortality benefit, but treatment based on PA catheter is being routinely done in the management of shock. Hemodynamics, you have three different things looking at it: pulmonary capillary wedge pressure, cardiac output, and systemic vascular resistance. And based on that, you can classify shock into three. Hypovolemic, when you have reduced pulmonary capillary wedge pressure, other things would be normal. Cardiogenic shock, which is what we are talking about, you would have reduced cardiac output, pulmonary capillary wedge pressure would be elevated, and systemic vascular resistance would be elevated, and you're looking at inotropes and revascularization. Neurogenic shock, it will be reduced capillary PCPWD and reduced cardiac output, and reduce systemic vascular resistance, where you have to give pressors and IV fluids. So in cardiogenic shock, you have reduced cardiac output. Treatment would be inotropes and revascularization. MCS devices is something which everyone treating shock has to be aware of. There are three main things that you're looking at. One is IABP, the other one is VA ECMO, and Impella. IABP is a dual lumen 7 to 8 French catheter, polyethylene balloon, inflating or deflating, synchronized with either the ECG or blood pressure. It increases the diastolic blood pressure, reduces afterload, myocardial oxygen demand, coronary perfusion, and it helps in ventricular unloading. VA ECMO, it's a 17 or 24 French venous cannula for taking out the blood, and that's given into the artery, that's the femoral artery or the central artery, but you need a 14 to 19 French arterial cannula. So you're looking at big catheters into the vein and artery, and this gives the largest cardiac output to the patient. There's a reduced venous return and increased systemic vascular resistance because the blood is pumped into the aorta or the femoral artery, and this results in a depressed LV. So systemic vascular resistance would be highly increased when you're doing a VA ECMO, and for supporting the ventricle, you would need an IABP or an Impella when you're using a VA ECMO. This is very important in cardiogenic shock. VA ECMO per se is not to be used because that will cause further worsening of the ventricle. Impella is the newer one. It's a non-pulsatile axial flow. You got three types: 12 French, the Impella 2.5, 14 French for the Impella CP, and 21 French, which has to be done by a surgical cutout. It's the Impella 5.5, which gives large output, but again, it has to be done with a surgical cut down. And Impella is the one that is currently favored, but cost is prohibitive. Now, again, talking about the types of MCS, IABP, the cardiac output increase is 0.5 to 1. With MPILA, it's 2.5 to 4, and with VA-ECMO, it's up to 4 liters increase in cardiac output. So you have the largest increase in cardiac output with the VA-ECMO, but the problem is the peripheral vascular resistance is increased, highly increased with the VA-ECMO, and you need to have LV unloading. This is a comparison of MCS devices. Again, you can see it's a pneumatic pump, cannula size is less, anticoagulation, yeah. Now, what is the data? Because for everything you need data. You have 3 main things: the IABP Shock 2 trial, which came in 2012, ECLS with VA-ECMO, and the Danger Shock in 2024. So what do we have? IABP did not reduce the 30-day mortality, 6 months, or even at 12 months for patients who needed an MCS. So with that, IABP has a class 3 recommendation, which means it's not to be routinely used. What about ECMO? This came in 2023, and in patients with acute MI complicated with cardiogenic shock, the risk of death from any cause at 30 days was not lower with VA-ECMO than with medical therapy, but had increased complications with bleeding, peripheral ischemia, prolonged ventilation, increased afterload, which could have contributed to it. So IABP, no use; VA-ECMO, again, no reduction in mortality. Then came the Danger trial. This was just published a couple of months ago. Here, Impella was used, and Impella, for the first time, showed a reduction in mortality from any cause at 180 days. There's the first MCS which shown some reduction in mortality, but the composite safety endpoint, that severe bleeding, limb ischemia, hemolysis, device failure, worsening aortic regurgitation, renal replacement therapy, sepsis, all were much higher. So it is not that you put an MCS and that's the end of the matter. You are looking at cost. This is upward of 20 lakhs, and you have so much of problems. But yes, there was a reduction in mortality for the first time with an MCS device. This important terminologies in shock with the cardiac pressure output. CPO, if it's less than 0.6, it's bad prognosis. And again, pulmonary artery pulsatility index, if it's less than 0.9, it's a measure of high mortality. Coronary angiography is the single most important investigation. 15% left main and more than 50% have 3 vessel disease. And mortality is associated with which culprit vessel is involved. In left main, more than 78% have a high mortality. And mortality is inversely related to TIMI grade flow. Now, what is the strategy? Should you revascularize all or only the culprit? And this is seen in culprit shock trial, which is in 2017 among 706 patients. The primary endpoint of death and renal failure leading to renal replacement therapy was lower among patients who initially underwent PCA of the culprit alone. So it's only culprit alone and not multivessel disease, multivessel angioplasty in case of a shock. And this is what's seen in the ESC guidelines as well. It's immediate PCA of the infarct-related artery only and staged complete revascularization. This is the National Cardiogenic Shock Initiative, which is the best practices like MCS pre-PCI, door to support of less than 90, establish TIMI flow, use right heart catheter or the PA catheter, wean inotropes. Inotropes has not to be given too much, but use MCS and increase MCS, maintain cardiac pressure output of more than 0.6, and aim for a survival to hospital discharge of more than 0.8. And this is tried in 406 patients with 70% survival to hospital. But this again is a team, not just intervention cardiology, critical care, vascular surgery, and even an advanced heart failure team, because the patients who have LV dysfunction would go on to LVAD and even transplant. So let's finish with the case. It's a 74-year-old man, diabetic for 15 years, brought with chest pain, more than 8 hours of onset of symptoms, blood pressure 90/60. So as per our criteria, it would be class B or still stable hypotension. The ECG shows inferior wall MI, ST elevation inferior leads, and this is the angiogram. You can see the OM1 is occluded. That's a culprit one. You got some disease in the ostial LAD, and which is very, very tight. It's ostium almost hanging by the thread. And again, RCA also has got a disease. So it is cardiogenic shock, triple vessel disease. What will you do? So as per the culprit shock, you would only be doing the culprit lesion. So it's whether it's OM1 or RCA, OM1 is occluded, RCA is 99%. So which is a culprit? Not entirely sure. And what to do with the LAD? So we plan to do angioplasty for the OM1, which is the occluded one, and elective PCI to LMC to LAD and RCA later. So this is PCI to OM1. He had a thrombosuction followed by a critical lesion here. You obviously have to, and initially we thought I will just do with a balloon and leave it for complete revascularization later, but with this you had to put a stent. So a stent was put with a good results, the OM1, but then started the problem. Patient goes into hyper, you can see the heart rate contractility less, the bradycardia, and ongoing chest pain, and you can see the LAD is kind of closing off. So what was thought will do as an elective procedure had to be done as an emergency, 2.5 into 12, followed by a Scoflex to see the left main to LAD, and a 3.5 into 33 stent was put from left main to LAD, and a port was done with a good result in the LAD, left main to LAD. So you have done the left main to LAD and the OM, but you still see the heart. It's still just not contracting. Heart rate is low. Still in bradycardia, chest pain, blood pressure 70/50, and the RCA angiogram which showed it's occluded now. So you started with the OM occlusion, then got worse, left main to LAD, but still RCA is now occluded. Thrombus aspiration, you can see the critical lesion in RCA, but again, the lesion in long lesion in proximal PDA. So where do you stent? Do you stent just the distal RCA or stent from RCA to PDA? So because the PDA lesion is thrombotic, I thought it would be better to put a long stent from RCA to PDA, and this is what you have. There's no flow distally. Now the question was whether the proximal part of the lesion was completely covered with the stent. What do? You post-dilate the stent, but still there's no flow. So you dilate the proximal part with another balloon to see in case that part is not covered. Still, there's no difference. And the patient is continuing to have chest pain, blood pressure of 70/80. So thought I would put another stent. So in case that part is not covered, just to make sure that is covered. And so there's no technical issues with the angioplasty, another stent overlapping the one end is post-dilated. But still, there's no flow distally. So you're losing hope, vessel is closing, thrombus, what next? IABP, you don't have an option, so Impella is out of question. What else to do? Is there anything else that you can try? So as a last resort, gave intracoronary streptokinase, 250,000 units, given via the guide catheter 1 ml every minute for 10 minutes, and this is the final result. Some improvement of flow, but still blood pressure was again 80. So talked to the family, said that the patient's prognosis is bad. I'm not sure whether he'll make it. This is the ECG at the end of the procedure. Atrial fibrillation, slow ventricular rate, ST is still high. But BP was 80/60. You not put 10 to 15 ml. But fortunately, he gradually improved. And BP settled over 3 to 4 hours. Urine output increased and hemodynamically better the next day. And there's an ECG the next day, which showed the ECG had settled. The STs had come back to normal. And I just wanted to know what is happening. So there's no indication. I just took him for a check angio after 40 hours, and you could see all the stents are flowing widely patent and it was flowing well. And even the RCA, despite all the problems, was still flowing well. Settled within 24 hours, the rest of the hospital stay was uneventful, discharge and aspirin clopidogrel along with anti-failure treatment. Echo showed RWM of intraposterior wall with moderate LV dysfunction. And he came for echo last week really, and I was quite happy to see this echo. It almost completely recovered with some hypokinesia of the inferior wall. So ACS with cardiogenic shock is dicey, associated with the high mortality, revascularization is the way forward, MCS depending on availability and the cost. You have to improvise and think on your feet, and individualized treatment is a key. Optimal results can be obtained even in difficult cases. And there's the ESC guidelines for shock. Immediate angiography and PCA of the IRA, class 1, CABG can be recommended, class 1. In case of hemodynamic instability and mechanical complication, again, surgery as after the heart team. Fibrinolysis can be considered as 2A. In ACS and refractory CS, short-term mechanical circulatory support may be considered 2B. Routine use of IABP, class 3. Thank you.
Thank you, sir.